tell me a little bit about you and your background.
So I've been a family physician for a long time, over 20 years now, and ran a residency for a little while, and was looking for personal reasons to make a transition, and was made aware of this World Bank partnership. So that's how I got involved. I used to do full spectrum family medicine, including obstetrics. Doing, full spectrum age was important to me, even though I wouldn't be doing obstetrics anymore. So we do see our youngest patient here has been 2 days old, and our oldest has been 90 years old. So
Wow.
at this office, located in a, employed building, we see, people who work there, their families, and retirees.
And how many people would you say you serve?
So the World Bank, it's someplace between about 10 to 15,000 people that actually work there and their families, between the World Bank, IMF, and the family members. There's another 10,000 that work overseas. So those people we see, on a much, much smaller basis, although interestingly, because there's an electronic medical record, some patients come into town, do their primary care, and then I correspond with them wherever they are. If they're in Zambia, then I obviously can't practice medicine there, but then, if so for acute care, they get it locally. But then when they come back to town, I help them coordinate any primary care things that they need while they're here.
Wow.
So it's a little bit serving a small village in a big city.
Yes, that is way cool.
It is super cool.
Tell me about the team that you have in your practice, in your group.
So we started off with myself and 2 nurse practitioners, and just got overwhelmed very quickly because we weren't sure what the interest would be. So the idea was to grow the practice over 5 years. Now, the acute crisis has kind of thrown a little kink in the whole system, but we currently have 4 physicians and 1 nurse practitioner, and that grew over 3 years. And I fully expect in the next year, once things get back to normal, we'll be up to 5 physicians and 1 nurse practitioner, and that's as much space as we have.
Great. And you're physically located where?
The World Bank has a number of different buildings. The World Bank and the IMF are kind of located side by side, and then the World Bank has a number of other kind of smaller buildings, around the same hub. So we're in the main World Bank building.
Okay. And how does it work? What's the what are the range of services that you provide in your practice?
So the original idea of this was the World Bank actually is an excellent partner. Which one of the unusual things about this employer, based care is I meet weekly with their health services department. So they have a doctor who basically manages their travel clinic. So dispensing Malarone and, their immunizations for travel, that's actually managed by a staff of nurses. And then the physician oversees that group and does health prevention for them. They actually have another doctor who oversees their occupational health department. And so they have, a number of health people kind of on staff that we partner with. They did a very good job before they ever even decided to go down this route with evaluating the health of their community. And when they did that, what they found was about a third of people, maybe it was more than that, I forget, a ton of people that did not have 5,000. Yeah, so a third of people did not have an identified primary care physician. So when we first came in, they had been doing some urgent care with just nurse practitioners, and they wanted to, one, be out of the healthcare business because, there's an issue with kind of medical records internally. And they knew that they weren't meeting, that people were struggling with primary care when they moved to the area. And, I met lots of patients when I first got here that were like, yeah, I couldn't even figure out the healthcare system here. So I just wait every 2 or 3 years till I go home. They found when they did that healthcare survey, one, the health indices were not as good as they expected. And then two, there was a really big need for primary care. So we came in with the charge of, I staffed it with family physicians because we wanted to be able to see all ages. Because the other thing that would happen is people would move from other countries and have their kids, and then they struggled with, getting vaccination updates, forms for school. So that was identified as a need up front. We had a significant transition the first year in just getting people on board with the primary care idea. So even though there was a need, like people, you're working with cross-cultural things. So a lot of times I'll say to people, look, I'm managing 11 of your healthcare issues. You have to come in for a preventive visit. Can't do it, like I'm trying to help you. And they're like, they've never done it that way before. So while some people understood the primary care model, some people coming from other cultures just didn't understand it. And we're kind of in this acute care mode. So, sometimes there was just some pushback of, well, you should just walk down and be seen. There was a lot of kind of self-directed behavior. But now, 3 years into it, I would say there's very good buy-in. And a lot of times what would happen is people would come down for whatever, an acute visit, and then go, oh, you do primary care here? Because we make it a standard part of our intake to say, do you have primary care or not? And so some people actually do just use us for urgent care. They'll have a primary, established primary care someplace else, and it's just for convenience. So we do kind of function as both an urgent care and a primary care. But I would say, like, at the beginning, I said to them, look, I can expand the urgent care till the cows come home. You guys have, but some of it's just little bits of stuff, and it's not going to get you anywhere. You really want us to, you want me to focus on primary care for the, the win as far as your healthcare parameters and making a financial impact. And they understood that, but there's a lot of, employee satisfaction of, well, I have a cold, so I want to walk down there. I was like, that gets you nowhere. So it's taken us, a few years to kind of change the model. But now it's very well received, and increasingly people are changing their primary care to us.
Yeah, that's great. So what's the range of services? What kind of things do you do in the office?
So we do, full spectrum family medicine minus obstetrics. So minor surgical stuff, a lot of GYN. We do, routine well woman care. We actually insert IUDs. We're, able to do minor germ procedures. And then, well child and acute sick visits for kids, well adult visits. So, really the full spectrum. We have, full vaccinations. Cool. Work in conjunction. Sometimes we're doing some travel, a small amount of travel medicine for like family members that aren't covered by the World Bank Travel Clinic. So we also do some travel medicine. We do return sick visits for when they're, been traveling and are coming back sick. So I've seen more malaria than I have in my entire life. So like one of their charges initially was they had some bad outcomes with malaria. So we worked very closely with Georgetown ID, and we have a whole malaria protocol. So including, for various reasons, we actually have a rapid test that has to be done in the travel clinic, but we rapid test them for malaria, and then based off of those results, we have a decision-making tree about where to send them.
What about things like behavioral health,
Oh,
dentistry,
yeah.
podiatry, things like that, physical therapy?
So not dentistry. We put a lot of attention into mental health initially. So I have a psychiatrist who's on site 1/2 day a week. And we actually have a collaborative care model. So now we have a part-time social worker as well. We're all, as family physicians, we're, very well versed in mental health. So, I mean, initially, honestly, with the collaborative care, I was like, I don't know if we need this because we're all so comfortable
Right,
with the psychiatrist
right.
site. I'm not sure we need this collaborative care model because we've all been, doing, um, you know, basic anxiety, depression treatment without a psychiatrist for years. It's great to have them on board. There's more mental health issues than I'd expect. So, it's really helpful to have the psychiatrist for people with bipolar and, more complicated mental health care needs. But honestly, the woman who did the collaborative care started right before this acute pandemic. Oh my God, I don't know what we would have done without her.
Really? Tell me why.
She's been so helpful with, initially in the pandemic, I think everybody coped. There's sure there was some people with some anxiety and depression that got worse, but honestly, it was at the end of the first, as I call it, the first quarter of the pandemic, when it really spiked. Right when people realized, oh, this uncertainty is not going to stop. That we really saw people struggling with anxiety. So she's been great as far as it takes us a couple months to get people in to see the psychiatrist, and so she's just provided and other therapists in the area. A lot of people just stopped accepting new patients because their current clients had greater needs. Everybody was running at 120% health field, so to have somebody in office that could do kind of short-term counseling was unbelievably helpful.
Wow, that's great to hear.
Yeah.
And so tell me about the outcomes of this. How is this working out?
So the other component to know is that simultaneously with launching us, they also signed a contract for their wellness program through a group called USPM. And that's the other kind of interesting thing. We've kind of partnered with them. So like I have them in the EMR to be able to receive messages from me. So if I'm in with a patient and they have like new onset diabetes, I'll say, can I actually send a message over to the nurse at your health wellness program, even though she's not part of MedStar, and then they'll reach out to you and, they have the ability to hook them up with a nutritionist. I would say we didn't have a lot of outcome data, except that they just met with Aetna in the last month. And apparently every year Aetna comes back with, we have, basically because Aetna administers their health plan, but it's really their health plan, right? They're so big, it's like their own health plan. So like they have very good mental health benefits that are way beyond what Aetna's plan is. So Aetna's kind of their health plan administrator. And
they're the third-party administrator.
Yeah. So they every year come back and say, what we predicted, you overspent based off of what we predicted, so we're going to charge you this much more money the coming year. This is the first year ever there was a significant drop. And I can't remember, actually I was trying to remember this, I'm so bad with numbers, but it was big. I mean, it was like $1 to $3 million under what they expected. So Jules, and this is a really important piece of information. So, and I don't know on what timeline that's going to come back. He actually hired an outside person to analyze it.
Ooh.
they think from a quick look that it is related to in-network referrals. I thought it would take a little while to change referral patterns, and it super did not. It happened really fast. And it was just, you know, one of the nice things about MedStar is their shared electronic health system. So about, you know, less than 5-minute walk away, there's a large multi-specialty practice that, for all intents and purposes, works like my Kaiser. So I, you know, oftentimes refer people to them or Georgetown. I also arranged at the beginning because people, when they come internationally, really struggle with our healthcare system because it's so wacky. So I arranged for somebody to help with referrals if they were going into Georgetown. So again, and she's in our, you know, medical record. So if I'm in the office with a patient and they need to go to, say, a gastroenterologist at Georgetown, I'll send a message to Kim and say, hey, can you contact this person and help them get it set up? So that's been tremendously helpful. And that, to me, that was key. And like actually coordinating, getting people in the system and having it work well. But they also just go over to specialists, and we're on a shared electronic medical record. So it really allows me to coordinate their care well, because, you know, I'll get labs and the specialist can see them. And if the patient comes back to me and has any questions, I just send a message right in the record. And so, and that for an international healthcare group, international group, that's been super helpful because they really struggle in the U.S. system.
Right. Right. So when you say that you're in-network referral patterns, you're talking about referring people over at Georgetown and over to this other multi-specialty practice, and you're all on the same electronic medical record.
Yeah, but I think the cost savings probably are that before people just kind of they were going to not in-network providers, specialists. You know,
Right.
it was a lot of, you know, sort of this, I wouldn't put this in the report, but or put it in a very political way, but it's sort of that international belief is the more money I pay for the person, the better they are.
Yep.
So people would shop on what we call the K Street corridor for these kind of high-end specialists, where it's really, as we all know, offer no benefit.
Yep.
So, so I think it's going to end up to be that. It would not surprise me if there wasn't savings around emergency room visits. I mean, I had patients come in. I mean, you know, it'll be interesting to see if the data is borne out. Because anecdotally, I had people come in to see me that just would say, yeah, I'm so glad you're here. Before I just used to, you know, go to the emergency room for my asthma. So I know that you know, I don't know if it's big enough numbers of those to be picking up on this kind of analysis, but, you know, at least anecdotally, we should have seen those improvements. And they were worried that the number would go up. I mean, it's kind of the perfect, you know, we just learned the same lesson over and over again. You think, well, you know, we're going to end up having to pay so much an office visit that it'll end up costing more. But to have, you know, again, the message of it doesn't matter if they come to see you more often, you still save if they're using primary care as a base. You know, I'm sure that we, you know, did, and I'm sure it also was balanced off of the, like, they're coming in because I want my dermatology referral. I'm like, well, you know, I'm happy to do that, but don't you just want me to treat your acne? I mean, like, why don't we just do that here? Or like, oh, that's fantastic.
So that, Pat, that does not surprise me. I've heard that time and again. You know, the general public is uneducated and confused, and they make decisions or have health beliefs about how things work or how things should work. And when they come to you essentially as their health coach, you either can take care of it or you can coach them on how to deal with it, and the costs go down.
Yep. Yeah, exactly.
So, what surprised you the most with this project?
How sick people were. I saw the highest
Oh,
cholesterols here I've ever seen in my life. Like,
really?
you know, yep, total cholesterol's over 300,
Hmm.
LDL's over 200. Was wild. And more hepatitis C than I've ever seen in my life. I mean, hepatitis B that I've seen in my life because, and I think it's partly, risks related to travel. They eat like crap when they travel. But people are coming, with international risk. So, the reason I see so much hepatitis B is because, you know, anybody who grew up in China didn't have good public health around hepatitis B at the time. So the population is really a reflection of people's conditions where they were, where they grew up.
Interesting.
Yeah.
I wouldn't have thought of that.
Nope. Really surprised me because I kind of, when I first started it, I was like, well, that's okay. This will work well. It'll be kind of interesting because it'll be an international group and that'll be interesting. And there'll be a bunch of like healthy, well adults and I'll get bored once, but I can get it set up and then I'll move on. When I got here, I was like, oh, no, this is not what I expected at all.
So,
So
just
it's
because you
been
have health insurance doesn't mean you have good health.
correct. Right. And people still have whatever risks they've carried with them into adulthood from wherever they grew up.
And how would you describe the population? Have you guys got demographics on the people?
Say it again. I'm sorry, Larry. What was the question?
The demographics on the people that you're responsible for.
Okay. Um, it's different than my previous ones, and just that, like I would say, a lot of the practices I worked in, it was kind of 25%, 50%, 25% as far as kids, adults, and older. And this, obviously because we're in a workplace, is much heavier in the, I would say 40 to 60 range, kind of mid-career people, and then also a sizable chunk of young adults. And then, I would say probably more like 5 to 10% kids, and probably someplace, I'd be interested actually in the analysis of this, probably 10 to 20% retirees.
Oh, really?
But, hmm
Interesting.
It's an unusual place in that when people retire, they have a whole area for retirees because it's such mission-based work. The whole mission of the World Bank itself is to end poverty. So that's also I had no idea what the World Bank did. I mean, the World Bank, actually um, uh, was very front line, like with the Ebola outbreak. Right now, man, these people are working like dogs on COVID-19. They're working like 12 to 14-hour days. So they're involved in, the World Bank itself is involved in so many kind of international projects. So they retire, and it's not like retiring from making widgets. So if they stay in the area, if they don't move back to their original countries, they oftentimes come into the building. One, to either like see other retirees or, meet with colleagues. A lot of them will come back and do some work after they retire. So I was surprised because they initially were like, oh, retirees won't come in. So I was very, very, very surprised about how many of them do. And
Interesting.
they're fascinating.
Well, it's got to be a wildly diverse group of people and interesting people.
Yeah, exactly. I mean, they literally are from all over the globe. Very, very smart, really smart population.
So, what's the breakout of the population in terms of of American-born U.S. citizens versus people from other countries?
I think it's probably about 80% international, 20% U.S., maybe 25%. But the way, I think actually probably isn't more than 20% U.S. It's largely international. Most people have, well, a number of people have been working here for years, so they've kind of assimilated somewhat, but the majority of them have been born elsewhere.
And if I can, what do you see happening in the future? What would you like to see happen in the future in terms of growing what you're doing or expanding, increasing your impact?
I'd like to see us continue the primary care, to grow the primary care base. Once we outgrow this space, I see that we might have kind of the acute care in a different space and really focus on primary care in the office that we're in. Kind of, I guess that's the main thing. We've accomplished a lot our first 3 years, so kind of continue to build this collaborative care model. Perhaps a little bit more coordination around preventive care. We have definitely been working with the wellness program, but I don't think we're maximized as far as kind of more targeted care management. I think that they've been acting in more of a traditional wellness program. And so we've been talking a lot in the last year prior to this acute crisis about a more targeted approach, kind of higher touch on the patients that we know are higher risk.
Right. So one of the things I'll mention to you, do you know who Joe Sugar is?
Nope.
So Joe's a senior level family doc out in California, and he's part of a growing number of family physicians that are doing what are called disease reversal. And they're taking chronic illnesses, diabetes type 2, heart, hypertension, a whole range of things, and intervening by helping people to start eating healthy with a modest amount of exercise. And they're showing that you can, in these very good numbers on this, you can get rid of diabetes, type 2 diabetes, in a couple to 3 months. And so I just mentioned that to you because you're talking about an area here that you might want to look into or think about as you're going forward. I think it's a growing movement. I know a number of family docs across the country who are now doing this and explicitly talking with their patients about disease reversal as opposed to management with medicine. So that may be something in your future.
Yeah, the model for this USPM group, the guy who runs that, or is their kind of main doctor consultant, is Ron. What's Ron's last name? And that's his sort of deal, right? That you kind of put people at 3 rests. And the idea, it's kind of typical wellness. We maintain the people in the 1, and we try to move people from high risk to moderate risk. Between you and me, I've never, I think it's hard to do a really good wellness program.
Yes.
But, the other thing that Duval will have is that wellness group has also generated, and they've actually have shown that they've made some progress in decreasing people's risk. So they kind of have that approach. I think it's really, really hard to get good care managers, and really take a hold of the people that are, identified. One of the problems with the struggles that they have is their privacy. They're really, really hyped on privacy, as you can imagine, as an international group, because they've come from countries where they don't trust their governments.
Sure.
So they haven't wanted to it's been kind of a no-go as far as releasing claims data to the wellness group for care management, which is kind of key to making that effective.
Right.
But definitely that's, God, I can't believe I can't remember Ron's last name. That's his approach as well, that we want to try to reverse people and move them down a risk category.
Right. Is he a family doc?
He he trained in primary care. I can't remember if it was family practice or not, but he has a preventive medicine. He then did a preventive medicine residency.
Okay.
He's been working in that.
Cool.
Jim knows him. Jim would be able to.
Okay.
Or I can come up with his name, but Jules will. I mean, that's something that Jules, I think, could add, because that's when they signed the contract with us for the primary care office. They simultaneously did this one with the wellness program, so he'd be able to drop something in about that.
Okay. And the employees, are they required to use your service, or are they free to go anywhere they want?
They're free to go anywhere they want. They transfer to us there's a couple different reasons. One, they did incentivize people by basically covering the copay.
Okay.
So if they come into our do a copay, $15 is amazingly motivating to people who actually make good salaries.
Yes.
And they actually talked through in the wellness program. We talked a lot about developing something to motivate people to, kind of the classic thing of if you go to your primary care physician, you'll get rewarded in some way, whether it was here or someplace else. So they're really not incentivized to come to us in particular. They do, like when they have, they had like a panel on COVID-19 for the World Bank community, and we get pulled onto that. So, we're kind of, they are very clear, again, because of, really a heightened awareness of corruption. When we first came in, they're like, we can't be seen as promoting you in any way, because people then will go, oh, the World Bank is benefiting from this in some way, even though it's not true.
Right.
But there is, a lot of kind of soft internal promotion in making people aware of what the services that we are. We've met with, like, they have a family services group that's all volunteer, and we've met with them, and we're very networked. The World Bank, when you talk about like a patient-centered medical home, they really are our community of services. So like they have mental health services that are also available on the World Bank side. So they have in-house counseling services. It's like, it basically functions as like an EAP, except they're physically here.
Gotcha.
And they serve both the internet and on-site community. So we work, very closely with them, kind of referring people back and forth. So, they really are, oftentimes when we're talking about referring people to community resources, it's resources that within the World Bank itself.
That's great.
We did go through the process when we first launched of, I think it officially came through in the last 6 months, maybe last 8 months. We got certified as a patient-centered medical home. We went through the NCQA process.
Okay. That's great. Well, Pat, you've given me a lot of information. I'm going to try to get this. It'll probably take me a week or two with what I've got going on right now to get this into a very rough first draft summary. And I can share it with you and with Jim and with Jules. And then we can take next steps.
Great. Yeah, happy to help. I'm always, I know you're a family medicine champion that just persists across the years, and we really appreciate it.
Well, thank you very much. Well, my goal, actually, I tell people this, my goal isn't to promote family medicine. My goal is to get to a better healthcare system so my
Right.
grandchildren have a better life, and family medicine is the best vehicle to get there.
That's right. I mean, honestly, right? It's not like this has been so interesting over 3 years. I'm like, huh, look, it worked. Just like they say it does.
Yep.
It's and you really don't know at the onset. I'm like, well, I have no idea whether this will just be a break even and you'll see improved, outcome things. I think, you will see an improvement, but honestly, I think that they were shocked as well, at the big difference. So, it is going to be very interesting if they do an analysis and it shows that we really did have a big part in that, because remember, their whole healthcare plan, not everybody comes to see us, which
Right.
means that if it really is, a lot of the impact has come from us, it's an impact for the patients that we see, which is not
Good
the
point.
entire population, which means
Right.
that, we would have an outsized impact compared to the rest.
So I can't tell you right now because I don't have the time. I have another call here just a bit, but I will send you a document about an employer down in Florida, Rosen Hotel and Resorts, that requires their employees, their 6,000 employees, to come to their family medicine-led practice, and they've saved, this is going to shock you, they've saved over the last 20 years $315 million.
Yeah. Yeah, well,
It's-
that's actually, it's sort of what these guys are finding. Yeah.
Yeah.
Yeah, that is fascinating. Love to see it.
Yep, I'll send it
All
to
right,
you.
I'll let you. Thanks,
Great,
Larry.
Pat, thank you very much.
All right, take care.
Okay, bye-bye.